Good evening and welcome to the Johnson Shoyama Graduate School of Public Policy's third annual Houston Lecture. I would like to acknowledge that while tonight's event is taking place online, JSGS's physical homes at the University of Regina and University of Saskatchewan are located on Treaty 4 and Treaty 6 land and the traditional homeland of the Métis. We pay our respect to our First Nations and Métis ancestors of this place and reaffirm our relationship with one another. We would also like to welcome those of you joining us from across Turtle Island, including those who have joined from Ontario, my home territory on Treaty 3 land, as well as Dr. Danielle Martin's home territory on Treaty 13 land. My name is Lindsay Cox, and I'm a Master of Health Administration student at JSGS and the Engagement Lead and Sustainability Officer at Jerry MedRisk. I'm also honored to be your MC for tonight's Houston Lecture. As cases of COVID-19 have reached over 726,000 in Canada, and over 96.2 million worldwide, our national healthcare system has been placed under extreme and unimaginable pressure. The pandemic has shone a light on the existing shortfalls of our health and social services, reinforcing the need for better policies. With my professional background focusing on equity of access to healthcare services and the Health Policy and Equity Foundation I'm receiving in my current MHA studies, I must say I'm very much looking forward to tonight's presentation. Knowing that we have people joining us from across the country, I would be remiss if I did not say a few brief remarks about our school. Established in 2007 by the University of Regina and University of Saskatchewan, the Johnson Shoyama Graduate School of Public Policy, or JSGS, is a joint provincial school dedicated to educating graduate students, public servants, and those across sectors who are interested in and devoted to advancing public value. With nationally accredited graduate programs and a wealth of executive education training opportunities, the school is widely recognized for its innovative professional training and research excellence. One area that speaks to me, and likely many of you joining us, is the school's focus on social policy and inequality, and more specifically, health policy. Through events like the Houston Lecture Series, JSGS is able to bring together thought leaders, academics, students, and community members to listen and learn about current issues affecting Canadians. Tonight, we are fortunate to have a number of individuals who have joined us online, including Dr. Stuart Houston, his sons, Dr. Stan Houston and Dr. Donald Houston, and his grandson, Adam Houston. Before I turn it over to our Executive Director, I would just like to take care of a few housekeeping items. We kindly ask that all attendees stay muted and turn off their video during the presentation portion of our event. Feel free to turn your videos back on for the Q&A session. The format for tonight's event is as follows. Following the opening remarks, our speaker, Dr. Danielle Martin, will present for approximately 40 minutes. For roughly 30 minutes following her presentation, Dr. Martin will entertain audience questions moderated by Amy Zarzechny, JSGS's MHA Program Director and Associate Professor. If you would like to ask a question, please use the Zoom chat function to submit your question directly to Amy. Because we have a large audience and a short amount of time, I would encourage you to keep your questions concise and to the point so our speaker can respond to as many questions as possible. If you have any logistical issues during tonight's presentation, please don't hesitate to send a message to Karen Jaster-LaForge via Zoom's chat function. I would like to welcome Dr. Lolene Burdell, JSGS Executive Director, to provide a few welcoming remarks.
Thank you, Lindsay. Thank you very much, everyone, for being here. On behalf of the school, I would like to welcome and thank all of you for attending what promises to be an engaging and thought-provoking evening. This lecture series, named after our gracious donors, Dr. Stuart Houston and his late wife, Mary, is a prime example of how we are facilitating dialogue and creating opportunity for evidence-based research in the areas of health, social, and economic inequality among all Canadians. Stuart and Mary Houston grew up in Saskatchewan and spent their lives and raised their family here. Through his practice of medicine and his deep involvement in Saskatchewan history, including books about Tommy Douglas and Saskatchewan's achievements in health, Stuart developed an insight into the intersection of health and politics, the critical importance of the social determinants of health, and the vital need for policies impacting health to be based on the best possible evidence. Stuart and Mary were pleased that JSGS has provided the means through which they can contribute to the development and dissemination of this evidence here in Saskatchewan. As a reflection of their lifelong commitment to social justice, particularly as it involves health and income inequalities, the Houstons, along with their family, established the Houston Family Trust for Evidence-Based Public Policy at the Johnson Shoyama Graduate School of Public Policy. We are very fortunate that Dr. Stuart Houston, his sons Dr. Stan Houston and Douglas Houston, and grandson Adam Houston are able to join us here tonight. Welcome. With their gracious investment, we are pleased to host the third annual Houston Lecture featuring the acclaimed physician and healthcare expert, Dr. Danielle Martin.
Thank you, Dr. Burdell. I now have the honor of introducing our 2021 keynote speaker, Dr. Danielle Martin. Dr. Danielle Martin is on the front lines of transforming the healthcare system. An internationally recognized health policy leader and executive, Martin is committed to revolutionizing healthcare to meet the demands of the 21st century. She speaks with passion on our national healthcare system, defending and defining the ways that we can make it even more worthy of our national pride. Currently, Martin is the Executive Vice President and Chief Medical Executive at Women's College Hospital, where she's also a practicing family physician. She's leading the creation of Women's Virtual, Canada's first virtual hospital, and helping to create a hospital that leverages digital tools to bring care directly to the patient, reshaping modern healthcare to be more accessible, timely, and innovative. Martin made headlines in 2014 when her testimony on the merits of the Canadian versus American health systems at a US Senate subcommittee hearing with Senators Richard Burr and Bernie Sanders went viral. The video received over 35 million views online, as well as worldwide media attention. A go-to media spokesperson, Martin frequently provides commentary on health issues and is a known health contributor for the CBC. She's also the author of the national bestseller, Better Now, 6 Ideas to Improve Healthcare for All Canadians. In addition, she's an associate professor at the University of Toronto and is frequently asked to advise governments on how best to improve healthcare systems. Martin has been named one of Toronto Life magazine's top 50 influentials, called one of the most powerful doctors by the Medical Post, and is listed as one of the Toronto Star's top 13 people to watch. In 2019, she became the youngest physician ever to receive the FNG Star Award, the highest honor available to Canadian Medical Association members. I think we are in for an engaging evening as she provides us with her thoughts on how Canada can deliver on the promise of Medicare.
Good evening, everyone, and thanks so much for joining this evening. It's a thrill to be back at JSGS, albeit virtually from my ping pong table here in Toronto. And it was a thrill to have the opportunity to speak briefly with Dr. Houston this evening by phone prior to tonight's lecture to offer my thanks for the commitment to evidence that this lecture represents. And it is indeed a big day for evidence today. Those of us who were watching the inauguration south of the border last night, I think all felt, or yesterday afternoon, all felt the same sort of thrill that among many, many other things, science is back. And we're back in a zone in North America where we can speak openly and freely about the role that science and evidence should play in public policy. But of course, public policy is about more than just evidence. And if you step back and ask yourself, what are the inputs to decision making in our public policy processes, we wouldn't really want to live in a world where science was the only input or evidence was the only input. It also matters what's feasible. It matters what's affordable. It matters what we're trading off when we make choices and decisions. It matters what the public wants and is prepared to accept. And it matters what values we are putting forward when we make the choices and decisions that we make. So although evidence is critical, and we're going to talk a fair bit about evidence tonight, one of the things that we always have to ask ourselves when we make difficult choices in public policy is, what are the values upon which we're making that choice? Now, I don't think quiz any of you in tonight's Zoom room. Many of you are participating in this evening from Saskatchewan, of course, the birthplace of Medicare. I don't have to ask or quiz you on who you see there on the left-hand side of your slide. That is, of course, Tommy Douglas, voted by Canadians across the land in the CBC's 2004 competition, the greatest Canadian of all time. And most of you will know the story of Tommy Douglas, in which he became ill with osteomyelitis, a bone infection in his leg as a young boy, and his parents were faced with a choice that he felt no one should ever have to make. Indeed, a choice that's made by families all over the world, including right here in North America every day, which is the choice between saving their son's leg or life and losing the farm, so to speak. And so Tommy grew up with a commitment to the view that no one should ever have to make that kind of a choice. And when he was in a position as the Premier of Saskatchewan to bring in universal publicly funded hospital care and then medical care, he did so, a model that then, of course, spread across the land. And it's important to remember that that was not without a fight. Indeed, not without a fight from the medical profession itself, and that ultimately it was that commitment to values that won the day. And where we are today is a very different scenario than Tommy Douglas found himself in the Saskatchewan of the 1940s, 1950s, and early 1960s, where most of us take this for granted. The notion that access to healthcare should be based on need and not ability to pay is seen as a defining social commitment of our country. And when you ask Canadians what it means to be Canadian, more than ice hockey, more than maple leaf, they will point as a symbol to our healthcare system, a sort of a bizarre phenomenon if you really think about it. Very few countries, you wouldn't find very many countries in which people would point to a set of insurance programs as defining of their social commitment to one another. But indeed, that is what Medicare represents for so many Canadians today. But is it really so simple as to say that we have a healthcare system in which access to care is based on need, not ability to pay? It's in fact more accurate to say, as my colleague PG Forrest often says, the social contract is as follows. If I am sick, I can go see a doctor. If I am really sick, I can go to a hospital. And that is important, of course, that we don't have the rates of medical bankruptcy seen all over the world in many other countries. And indeed, that people do not, in the face of, for example, the pandemic that we find ourselves in right now, people are not having to make horrible choices about putting food on the table or having a COVID-19 test or wondering if they'll be able to pay the mortgage because a loved one is in the ICU. But that is perhaps where the equity ends and a much more complex picture emerges. When we look at the structure of Canadian Medicare, in fact, we have layers of different kinds of services. The first, or what we call Medicare, is truly just about doctors, hospitals, and diagnostics, in which we have universal single payer systems. And beyond that, we have a hodgepodge, a mix of public payment and private payment, of for-profit delivery, not-for-profit delivery, not only for-profit delivery. We have services which are almost entirely privately funded. A bizarre decision, for example, that we've made as a country, that the mouth is not part of the body and therefore will take care of you if another body part ails you, but if you need to see a dentist, you're on your own. And so in fact, to talk about the Canadian healthcare system is to talk about a complex set of layers, a set of policy choices that have been made over time, some of which I would say are defensible and others of which are downright puzzling. So before the pandemic hit, the Lancet, the most prestigious medical journal in the world, in 2018 put out a special issue about Canada. And I was privileged to be part of the group that participated in writing the core academic article for this, in which we were asked to identify what are the top 3 challenges faced in Canadian health systems today. And, after a fairly exhaustive process, our group named 3. The first is that wait times for elective healthcare were too long. The second was that services outside the Medicare basket, outside that core doctor and hospital basket, are often inaccessible. And by that, I mean things such as pharmaceuticals or pharmacare, long-term care, home care, dental care, physiotherapy, mental health services outside of a psychiatrist's office, and you all know the list well. And the third, of course, is that Indigenous health disparities were unacceptable. That was 2018, at a time when no one had even heard of this coronavirus, and we weren't facing any of the particular stresses and challenges that we find ourselves facing today. And so what my colleague Nadine Caron and I want to acknowledge with great gratitude the collaboration that she and I have been writing about most recently and thinking about most recently is what's happened to those three key issues that we identified pre-COVID as a result of the pandemic. And what we believe is that those cracks in our pre-existing systems have in fact become chasms. That we find ourselves in a situation now as a country where a set of issues that we were able to sort of skate across or paper over have become so dire and serious that we have no other choice but to address them in a very profound way. But also, and I'm sure you can all relate to this in your own lives, that despite all of the horrors of this pandemic and all of the ways in which we've uncovered and deepened inequities and challenges and problems in our social fabric, there are also gifts. And I want to make sure that we leave this evening with a clear sense, not only of where those chasms are and what it is we need to do about them, but the gifts that we have uncovered as a result of our collective actions on this pandemic that we should not lose sight of. When we saw, and I'm sure you all feel the same way, the photos on Twitter of Italian healthcare workers with deep dents in their faces from their N95 masks, and heard stories about people having to choose who would get the ventilator as we prepared to deal with the first wave of COVID-19 cases in our healthcare systems in this country, I would say that the feeling in the healthcare system of providers and system leaders was nothing short of terror. We were all terrified. And we rushed and worked in ways that I continue to believe were very impressive to prepare for that very particular kind of strategy of tragedy. We put a lot of work into trying to put in place surge plans and double surge plans. What happens if we need to open field hospitals? What happens if we need to build ventilators out of a paper towel roll? What happens if we need to choose? And we were saved from that particular kind of tragedy. Of course, not by any heroic acts in particular of our healthcare systems, although frontline workers worked very hard through that first wave. We were mostly spared that particular tragedy through the actions of every Canadian, through the public health measures that were put in place, through the willingness of people to sacrifice family events, sending their kids to school, traveling to their workplace, people perched on couches, trying to get an internet signal, working from home, people losing their jobs and ending up on income supports of various kinds, everybody contributing some in ways that they chose and many in ways that they didn't choose to try to prevent that system overload. And certainly in the first wave, that was successful. The second wave, I think, in most Canadian provinces and territories, that conversation, is ongoing. But what we didn't really think about and talk about in those early days, way back, early last year and into the spring of last year, was what other kinds of tragedies might be unfolding as a result of this virus. What kind of death what does a COVID death look like? Is it solely a death through viral infection? Or does a death by suicide as a result of a job loss and economic hardship count as a COVID death? Does a death in long-term care as a result of low-wage workers having to work multiple part-time jobs in order to make ends meet count as a COVID death? And so really thinking in the broadest terms about what it is that we've learned as a result of this pandemic, it's clear that we were avoiding a very specific kind of tragedy and that our lens was not wide enough as a nation when we considered the very serious problems that we were up against. And so what happened was a very different set of headlines. Instead of headlines about not enough ventilators and not enough hospital beds, we saw headlines about deaths in long-term care, about people's surgery being canceled and then rescheduled and canceled again for their cardiac condition or for their cancer, about people who contracted COVID but didn't have a safe place to quarantine or to recover while sheltering in place, about people dying of overdoses and no one to help them. And so a very different set of issues emerged and declared itself. And the question that we have to ask ourselves is, how does this relate to those three earlier problems, the pre-existing challenges that we faced before the pandemic arose. Are these issues really new? Are the problems we're seeing in long-term care really new? Are any of these headlines that you see on the screen before you really representing news at all? Or truly is none of this news, and in which case we have a much more serious look in the mirror that's required. So let's go back to those three challenges. You remember what they were. The first one was that wait times for elective care are too long. Well, where are we at today as a result of that pandemic? Across the land, in order to create capacity in our health systems, we had to slow down, and we have now had to slow down, where I am here in Ontario a second time, the provision of elective services. That means, of course, thousands of surgeries being canceled. It also means, and this doesn't make the headlines quite as much, thousands of Canadians who've been waiting to see a specialist who've had their appointment either canceled or moved to a phone or a virtual appointment that may not have definitively dealt with their issue. It also means kids who haven't had their well baby checks and therefore have missed the opportunity to have an early learning disability picked up. It means people who haven't had their immunizations, children who haven't had their immunizations. It means screening pap tests that haven't taken place, and screening mammograms that haven't taken place, and colon cancer screening that hasn't taken place. And so we know that the effects of that will have a very long tail in the healthcare system, and more importantly, in the lives of Canadians. As we try to pick up the pieces post-COVID, we're going to have to grapple with a system that was already groaning under the weight of wait times, and we're going to find ourselves in a much more difficult position. The question is, how do we turn that challenge into an opportunity? Issue number two, of course, was that services outside the Medicare basket are often inaccessible. Like many of you, I have often found it at best puzzling, and at worst just this side of criminal, that a person can come to my office, declare themselves to be having a symptom or a concern, that I can talk to them, examine them, if necessary, send them for tests, if required, send them to see a specialist for a second opinion, and do all kinds of things to reach a diagnosis. But when I hand them a prescription to deal with the issue at hand, they're completely on their own. The absence of pharmacare in this country is not befitting a 21st century healthcare system. And indeed, Canada, as many of you would know, is the only industrialized country with universal healthcare that doesn't include prescription medicines. So what happened with COVID? Well, as we know, Canadians, as they lose their jobs, lose their healthcare coverage. And so we've ended up in a situation in which Canadians are twice as likely to have lost their prescription drug coverage as to have gained it over the last year. And if you think about the impact of this pandemic on people's mental health, we know that there have been huge, and will continue to be for many years, huge mental health ripple effects of the pandemic. This is not just an infectious disease that's here and then gone in 14 days. People who've suffered and survived COVID have long-term health effects as well as mental health effects, and all those who've been affected, whether through their employment, through the loss of a loved one, or through a variety of other traumatic events, not the least of which is the rise in domestic violence across our land. The need for mental health services for people that are covered has never been more acute. And so we find ourselves again in a situation in which we knew this. We knew that we had a system that was designed for the 60s and not for the year 2021. And yet our failure to have acted upon it put us in a situation where people are very much at risk. And finally, a few words on Indigenous health. It is an extraordinary story of self-governance and resilience to have seen how well First Nations living on reserve in this country did in the first wave. An extraordinary story of commitment to the health of elders, one that the rest of us would have done well to learn from. But nevertheless, there's been tremendous suffering. And in the second wave, our Indigenous communities, in particular in urban environments, but also now on reserve, have been extremely hard hit during this pandemic. The First Nations Health Authority in BC reported huge rises in overdose deaths among Indigenous people in British Columbia during the beginning of 2020 as compared to 2019. And, those overdose deaths, which are often deaths of not truly deaths by drugs, but deaths of despair, of loneliness, of untreated addiction, of course, but also of distance from one's loved ones, emotional and physical, and the result of intergenerational trauma and colonization, which continue to scar our country. And so the question is, what's the good news? Because it would be really terrible for me to leave you all with nothing but a horrible set of things to say. And I think it's critical that we acknowledge that in addition to having unmasked all of these challenges in our health systems, the COVID-19 pandemic has also broken log jams for us that were long overdue to be broken. So let's talk about what a few of those are. So, I'm sure we'll discuss in the Q&A, I hope we will, the role that virtual care has played in this pandemic. In some instances, it's been done extremely well. In other instances, not so well. The person you see there, Dr. Payal Agarwal, is a family doctor working in my organization who's running a program called COVID Care at Home, which has been an extraordinarily successful remote home monitoring program for people living with COVID-19 infection in their homes, a means to help people to stay connected, to have their questions answered, to monitor their physical health, and importantly, to make sure that they can get very practical things like groceries, like advice about how to isolate themselves from their families, whatever the setup is at home. And I know that a similar program exists with public health nurses, in this case, just simply using the phone across Saskatchewan, that's been very well received. And that in particular, this has been a method to reach people from underserved communities who really need that support. It's been fascinating to see the explosion of such programs across the country as a result of this pandemic. We went from almost no one being able to have an email exchange with their doctor or a video call or even a telephone call with their healthcare provider to almost all business being done this way that can be done this way in a healthcare system overnight. And like all workplaces, there have been upsides and downsides to that conversion. I don't imagine that we will sustain this level of virtual care, nor would I say that we should. But I think there are critical lessons, and just as is the case in so many industries, we will not go back to the way that things used to be. The challenge that we've set for ourselves in my own organization, where we're launching Canada's first virtual hospital, Women's Virtual, is very simple. If I am going to ask you to get on the subway or to drive to my organization, to park in the basement for $24, to sit in the waiting room for 45 minutes so you can have 10 minutes of FaceTime with a healthcare worker, it should be because that is the best way to deal with your problem. It should be because it's what you need and the best way to help you achieve your health goals, not because that's the only thing we've got on offer. And so healthcare, being a fundamentally human enterprise, will always involve in-person care. And as you see in the model on your screen, we envision always having face-to-face healthcare provided in our hospital and in health systems more generally. But there are lots of other ways to deliver services to people who are having an experience of illness. One, for example, is care, what we call care at a distance, which includes everything from that phone call to the video visit or any other, whether secure messaging, email, or any other way of interacting between patient and provider. The next layer, which I'd be delighted to expand on more in the Q&A if there's time, is what we call connected expertise. This is where providers give advice and support to the provider who's closest to the patient. So what do I mean by that? As a family doctor, I can get advice from a specialist by phone often in a 5 or 10 minute phone call that will save you months on a wait list to see that same specialist. The emergence of e-consult, which is a method by which family physicians and other primary care workers can get advice from specialists through essentially a secure email portal, also reduces wait times and allows people to get advice quickly in a way that is much more beneficial to the patient. This works for providing backup to long-term care. It works for providing backup to home care. It works for providing backup to primary care, and it works for providing backup to social services. Many interesting models that we're seeing, for example, in the mental health arena with social service providers, whether it's in shelter environments or in other environments, who are really closest to the client, being able to speak on the phone with a physician or a social worker or a more experienced healthcare provider or a psychiatrist to get advice on how to help the person sitting in front of them, rather than sending everybody to the emergency department because there's nobody else, and there's no other way to get that advice. And then finally, the role of what we call enhanced access. So this is really about providing people with the tools they need to manage their health in their own natural habitat, in their homes, out there in the world, in their communities. And for us to stop imagining as healthcare workers that what matters is the 5 minutes that they spend with us. Indeed, what matters is that the 99 point whatever percent of the time that they are spending without us, they're watching over them. And so providing people with the tools, whether that's simple self-monitoring, whether it's apps, whether it's remote monitoring of a variety of types, whether it's online education, whether it's online groups and peer support, the list goes on. And so you can see that when you combine all of these methods of providing healthcare, you have something that starts to look like an ecosystem. You have something that starts to look like a range of options. And you can see that then the in-person care is reserved for those instances where it's the most appropriate thing. And that is how we can use virtual care to reduce wait times in this country. It's the model that we're pursuing. And I think that we're going to see more models like this emerging across the healthcare system. In many ways, the pandemic was the kickstart for a lot of those models. The second piece of good news, which relates to that basket of services outside Medicare, is that mental health is on the agenda and it won't be going anywhere anytime soon. One of the things I want to applaud our governments for across the country actually is the speed at which they decided. I think virtually every provincial and territorial government decided to beef up their mental health, publicly funded mental health supports for people. It may not be enough and it may not be perfect, but the reality is, I see this, in my own practice. Every time I go to clinic, people are suffering, they are scared, they are lonely. People who have long had a predisposition to depression and anxiety have tipped over the edge. People who've lost their drug coverage have stopped taking their medications. And the ability to get even on the phone with a mental health worker and have a conversation, to have access to a course of cognitive behavioral therapy that's funded by the government, has been a lifeline for many, many Canadians. This is one genie that I don't think we can get back in the bottle. And then finally, and this is by no means the last piece of good news, but a critically important one to point out, is the recognition that you cannot deal seriously with a pandemic or with any significant shock to our health and social service systems without thinking about income supports. We all know that income is the most important determinant of health. And finally, we are beginning to see a modernization of our income support systems in Canada through programs like the CERB and other income support programs that have been put in place that are much simpler, that are run through the tax system, that are very rapid to respond to the needs of people. And we all know someone for whom the CERB made a difference between making rent and not making rent over the course of the last year. I'm incredibly grateful for this 21st century version of income support in this country. And I think that I hope that it is the beginning of a movement towards a true basic income guarantee in this country, one that is long overdue. Finally, and I mentioned this briefly earlier in my presentation, we've seen extraordinary examples of Indigenous leadership, not only in public health measures. It's interesting, you hear people talk about the Atlantic bubble with admiration, and of course it's an extraordinary thing, the extent to which Atlantic provinces were able to protect their borders from COVID-19 over the spring and summer and into the fall of this past year. But indeed, similar decisions were made through self-governing Indigenous communities all over this country that I don't think got the press and the applause that they deserved. And so as much as we see Indigenous communities struggling in the second wave, as we all are, I think it's important that we look to the ways in which Indigenous leaders and Indigenous communities have really stepped up to face this opportunity on their own terms, to shape the way that services are going to be delivered for their people. We've had the privilege in my own organization of providing some minimal support to Indigenous partners in outreach testing and now in vaccination efforts. And I have to say, it's been a truly inspiring opportunity. So here we find ourselves. I mean, we had a system that was not perfect to begin with, some very serious problems that we were facing as a country that we seemed to be sort of happy to limp along on and not really get to the root of. And then we were hit with this massive shock. It's one that we're obviously not through yet. There are tremendous hills still to be climbed. We've learned a lot about how we care and don't care for our elders in this country through the horrendous lessons of the long-term care deaths that we've seen, with over 80% of deaths in this pandemic occurring in long-term care facilities. We've learned a lot also about those things that we knew and yet seemed to be stuck on. And where I want to end before we open up to questions, I think I'm almost exactly at time here, is to say that I really believe that we are at a crossroads in this country today, that if we make smart choices about what we recover into in the post-pandemic world, we will have finally unlocked ourselves in places where we were deadlocked actually for generations. And so the challenge that we have now is how to ensure that the policymakers and decision makers of our country really take those lessons to heart. And I think for each of us as citizens, all of us experiencing these lessons in different ways, it's going to be up to us to put the pressure on decision makers to ensure that we actually shape the health system we want, one that does live up to our values and to the promise of Medicare. Thank you.
And thank you, Dr. Martin, for your thought-provoking presentation and interesting Q&A session. I think a number of things stood out for us tonight, and I would like to highlight your comment. The lessons from the pandemic provide a way forward. It's up to us to use them to shape the health system we want, whether that's by addressing the social determinants of health and moving forward with the understanding that healthcare should be based on what is the most appropriate method of care and perhaps provided through a variety of channels. It's also critical that we push policy through the long-term issues such as wait times for elective care, services outside the Medicare basket still being inaccessible, and addressing Indigenous health disparities. As Dr. Martin noted, we are at a crossroad. Blocks have been broken down in some areas, and we need to make sure policymakers move forward, and we can all play a part in that by rolling up our sleeves and finding solutions that create higher impact action. Before I conclude the third annual Houston Lecture, and on behalf of the Johnson Shoyama Graduate School, I'd like to offer our deepest gratitude to all frontline healthcare workers who are working tirelessly to help keep our community safe from COVID-19. Your courage and dedication to providing essential care is inspiring to us all. You are the true health heroes. And to all others who have joined us tonight, thank you so much. For more information on upcoming JSGS lectures or to learn more about our programs, visit us online at www.schoolofpublicpolicy.sk.ca. Thank you and good night.